I'm really excited.
Great, great.
Hello, everyone. Come on in the room. Come
Welcome, welcome.
on in.
Okay. Can you hear me
I'm gonna,
okay, Dr. Lacey?
yes, sir. And I'm admitting, so I am your host today. Hello, everyone. We are so excited to have you here. Dr. Ortiz is with us, and I am going to serve as your session monitor.
Okay.
So I will
Perfect.
do a formal introduction to Dr. Ortiz. I'm going to give a couple of more minutes, Dr. Ortiz, and then
Sure, sure.
I'll read your accolades.
Wow. You don't have to do that. Just tell them,
You sure? Well, what I'll do is I'll just talk about how we know each
you can
other. How
still,
about that? I
just tell
love
them how you
it.
know me. That'll work.
Absolutely.
There we
As
go.
you all are coming in, welcome. I am Dr. Lacey, and I am serving as the monitor for this session. So glad you all are here. Come on in the room. I just want to give a little bit of a background on how I know Dr. Ortiz. Dr. Ortiz and I were classmates so long ago at the
Mhm.
University of Texas. Well, I know you're not that old, but I am. They can see the gray halo. At the University of Texas at Arlington, we were in the master's social work program, and then we came back around and met each other through Miss Gloria Jackson when Dr. Ortiz was at Eastfield College, and I was finishing up my PhD, and they gave me an opportunity to teach. I had been a student working on my associate's degree so long, very long ago. But they gave me one of my first teaching opportunities, and then we've just been able to work in collaboration. We're currently working on a project in collaboration with Eastfield College. Dr. Ortiz teaches in our counseling program. So this is just good family conversation. And so I want to introduce Dr. Philip Ortiz, who is my colleague, my friend, and a co-collaborator in affecting change in our community. Take it away, Dr. Ortiz.
Oh, thank you, Dr. Lacey. That was too kind. I really appreciate it. Definitely, it's definitely nice to be amongst colleagues and friends. And I'm going to go ahead and it says the host has disabled my screen sharing. So as soon as I get those privileges, I will share my screen and get started, and then we can move forward.
Okay, let's see if you have that. Let's see if you have it now.
Okay, there, great. I think I can do it now. Fantastic. I was running right there. Okay, give me 1 second. Okay, and hopefully everybody can see that. If you do not, please let me know. All right,
yes, sir.
please welcome.
We see it, and we will manage your chats as you talk.
Perfect, please. I appreciate that. Perfect. All right, so again, thank you very much, Dr. Lacey. I appreciate that. Dr. Lacey is the current dean of the School of Counseling and Human Services, so I am very privileged to be able to teach as an adjunct instructor for her. And kind of how I ended up doing this is really interesting. And so it was kind of funny. And so I don't know, I think earlier this morning, she did mention, shout out to another one of my peers, Professor Gloria Jackson, who called me up and said, "Oh, Philip, we need to do a presentation in July." And I'm like, okay. And if you know Professor Jackson, you know the correct answer is always, "Yes, ma'am." And so I didn't even know what I was going to do. I just knew I had to do something. So, I'd been working on a topic and I'd be interested. And so I thought, you know what, let me go ahead and do that. So anyway, what I've been doing, in addition to working at UNT, is also I serve as a full-time social work faculty member at the Eastfield campus for Dallas College. And up until December, I was the program coordinator for that program. I still teach there full-time, but no longer doing administrative duties, which is kind of cool because it gives me more time to do other stuff. So I want you guys to take some consideration that this is not really, how can I say that, I'm not a full-time researcher per se. I'm really kind of an educator / practitioner. So I still have multiple contracts that I manage and work, and I still try to stay very active in the field. I'm still currently licensed. And I like doing that because it kind of gives me great stories that I can share with my students in class and whatnot and so forth. So I'm glad you guys are here. Welcome. I bet you didn't know this, but they say the best one for last. So we're going to go ahead and knock it out the park. My understanding is I got 3 hours. Oh, I kid, just kidding. I'll be done on time. I promise, Dr. Lacey. All right. So here's the game plan, what we're going to do. So, I'm going to talk about, the purpose of this presentation. And so hopefully bring to light kind of what our goals are and what we're talking about. I'm going to do brief recap, some history, which I think will definitely tie into what Dr. Torres mentioned. I was able to catch the tail end of President Mong's address, and then I caught Dr. Torres' keynote address. So a lot of this, there is a little certain degree of overlap, except I'm going to focus more on what's kind of happening in Texas. Whereas he talked about it on the national scale, I'm going to focus a little bit more on what's going on right here locally in Texas and within a couple of the counties. And then talk about a little bit in relation to disparities, some inequities, treatment recommendations, and throw out a couple of cases that I've been working on to kind of just see what you guys think, and hopefully try to create some realness about what's going on in our society right now, specifically as it relates to working with Hispanic Latino populations. And then it'll be open up for any comments, questions, or complaints. Either way, the complaint department will be open at that time. All right, so let's move on. That's kind of my outline. I always like to know when I'm doing a presentation, well, what is the guy going to talk about and what's the schedule or the itinerary? So this is y'all's itinerary, so take a look. That's what we're going to be moving forward with. All right, so this is not a research study, but I like to think in terms of research design. And so mainly because, Dr. Lacey has been teaching the research methodology class at UNT. So I'm always telling my students, you got to be crystal clear, you got to make sure you know what the purpose is and what's guiding your research project. This is probably something I'm going to carry forward and turn into a full legitimate research study, but I'm still kind of at the preliminary stage of kind of collecting some information and kind of getting a sense for what's really happening. And really, it kind of, I think can be captured by 3 points. So these are the 3 questions I have. These are 3 things I was interested in. One, we all know that COVID has had a significant impact in our communities, in our society, and really across the world. Significant, super duper significant. But what I want to know is, what's it been like for Hispanic Latinos? Because I have some ideas, but I want to know, is it affecting us any differently in comparison to other populations? And then if so, what has been the impact on treatment services? How is it affecting substance use disorders? How's it affecting mental health services? And then assuming that RQ1 and RQ2 are true, what does that mean for us as service providers? What does it mean for you guys? As future, I suspect a number of you guys are, counseling students or social work majors or whatnot. What does that mean for you guys going forward in the field? Especially since I'm assuming you live in Texas. Well, we know a significant portion of the population is classified as Hispanic Latino. So that's important to take into consideration, because a number of your clients are probably going to be or have been significantly impacted by what's going on. So those are 3 questions, and I want you to keep them in the back of your mind because we're going to come back to them in a little bit. All right, so let's move on. So before we do that, I'm going to invite you, let's take a walk down history for just a minute, if you will. Because it's really easy to kind of put the bad stuff behind us and say, oh, it's over, we ain't got to worry about it no more, let's move on forward. So let's travel back in time, if you will, and this was taken from the Yale School of Medicine. And I remember back in December of 2019, chilling, it's Christmas time, I'm planning a big birthday party for the missus, everything's cool. And I start seeing these news feeds pop up, that there's some, mysterious illness going on in China. And then they begin to call it COVID. And I'm thinking, this is not going away. I keep seeing this coming up. So I think this is something I probably need to pay attention to. Because, I'm always kind of on the lookout. I'm a planner. I like to plan and prepare. I'm not a doomsday prepper, but I like to be, prepared in advance. It's better to be safe than sorry. And then, of course, as we know, right, going into January, then COVID-19 is identified by the World Health Organization. And then the virus quickly spreads out of control. I think the first case outside of China was in Thailand. And then you see going into by March, then it was hitting San Francisco and California. And then there was that, the famous cruise ship that was docked because there were passengers that were testing positive or were showing signs and symptoms. And it was crazy because I actually was in Puerto Rico with Dr. Torres and some of my colleagues doing some training in February. So fortunately, I made it back right before everything went crazy. And then here we are, we're at spring break, and then everything starts shutting down. All colleges and schools, they go online. Now we start getting ready to go into quarantine mode. So it was kind of crazy if you think about it, So just a little about a year and a half ago, that's kind of what we're going through, not knowing what's going to happen. Now, fortunately, at Dallas College, or previously, which was Eastfield College, we were okay because I had already streamlined 60% of all of our courses were already in 100% online format, because that was just the demand was had been steadily increasing over the years. So going to 100% online was not that much of a difficult task, right? We just easily did it. But that's at college. Now, think about what people were dealing with at the secondary level or at the primary level. It's kind of a challenge. I mean, how do you take a kindergartner or first grader, third grader, just have them do classes online? That's pretty wild, right? So a lot of people were just kind of really just left not knowing. In a lot of school districts, they weren't ready to do that kind of shift to 100% online. Now, here's another case. I had a client who came in and he moved here from Las Vegas. And he told me, and because, we were talking and I asked the parents, so, tell me, what concerns do you have? And then they said, well, we're really worried about school coming up this year. I'm like, oh, yeah, a lot of kids are. So what's the problem? I'm like, well, whenever, he didn't have school when he was in Las Vegas because we shut down for quarantine. I'm like, oh, yeah, we did over here too. But, he had online access, right? Was no. What do you mean no? He was like, well, they just had us, send in an email to confirm his attendance, and that was it. There was no online instruction. So basically, he went half a year with nothing, okay? And then he got in trouble after the summer, so then he was sent to alternative school. And then he got suspended or kicked out of that. So this kid basically had a year and a half off with no education at all. So of course, anxiety is up, there's academic deficiencies. He was already identified as having ADHD prior. So it's just kind of having a ripple effect. So a lot of people were kind of slammed in the turmoil of having to transition at that time. Then we're like, okay, we're trying to flatten the curve. We're trying to, make our shift and, reduce the numbers. And then finally around, if you remember in Texas, then, our governor said, that's it, we done. We're just gonna lift everything. We're opening up everything. We're everybody go back to work and so forth. But by that point, it was already kind of too late. We were already beginning to see the economic impact of shutdown and quarantine. And so a lot of stuff was kind of happening. And then, of course, then the government starts handing out, the stimulus, and then there's a lot of, debate about that. There's unemployment, but then I think around June or July, then they were looking at separating it per state and saying, okay, you guys can start, reducing the additional pay they were adding in for unemployment. So that was a lot going on. And even some of my peers and colleagues at, at Dallas College, we did our big recreditation and restructuring. So a lot of people were just, instantly out of jobs. I had a colleague of mine who was a division dean. Well, I had two actually. They were both division deans, and they literally hopped onto a Zoom session, and the HR director said, "I'm sorry, but we're going to have to, terminate your employment, and we're going to give you 1 month severance pay. 1 month, that was it." So, and crazy, insane. So we had all that happen, and then we finally going into late last year. Then we have a vaccine. Or we have a couple of vaccines. So now there's new hope, because we've got a vaccine to fight this illness. Keep in mind, though, the vaccines are currently, they're not FDA approved, but they are FDA authorized. Or actually, I think they're EUA, or authorized for emergency use, because they're still collecting clinical trials. But nonetheless, we have some vaccines, and so we're pushing, and so now people are getting vaccinated. So that's kind of saying, goodbye to coronavirus. So we should be okay, right, guys? So at this point, we're moving to 2021, and we've already kind of seen the rollout. So the pandemic is pretty much coming to an end, correct? So if that's the case, why are we talking today? Okay, what's the problem? What's the issue if that is happening and if it's all behind us? Well, the problem is kind of the damage has already been done. And so we have to look at the aftermath, and that's where you guys become important. That's where they need us. And I'm going to provide both some quantitative data and some qualitative information to help you think about that. So honestly, I'm going to be real with you guys. Can we be honest? Is that okay? So honestly, it's a great time to be a counselor or social worker. Huge demand. So let me tell you, if you are working as a mental health provider or in real estate, it's a great time, because there's just, the business is booming. And I hate to say it, and I'm saying it jokingly, but the reality is it's very unfortunate because a lot of people have been significantly impacted. So here's what's happening in Texas. So let's look at the good old state of Texas. All right, so far, according to the Texas HHS, we've had currently, and this is current as of, I think, July 16th is when I pulled these numbers of this month, and July 21st, they were up in the process of updating the database. So currently, we had confirmed over 2.5 million cases. This is not probable. Probable is an additional 500,000. So we had 2.6 or just under 2.6 million cases. Here are the three largest counties: Harris, Dallas, and Tarrant County, which had the highest hit of positive cases. And then we had over 51,000 fatalities as a result directly related to COVID infection. And of those, the Texas Department of Health and Human Services, they were able to isolate and pull about 80,000 cases to do intensive case investigations, where they really pull out a lot more detailed information. And that's really where we can kind of unpack this a little bit to kind of see what's happening, because it gives more information. A lot of times the tests are reported, but we don't know any of the details. We don't know the ages, we don't know the ethnicity, the gender, the code, the county. We don't know a lot of information sometimes, so I can't really look at the whole larger sample. So think about this think of it in research terms. The 2.6 million, that would be like the big N or the capital N. That's like our population sample. So of that population of 2.6 million, we're going to extract about 80,000, 80K. And this is going to be like a little lowercase italicized N. This is really more of our sample size we're looking at. So I'm going to look at this 80,000. Let's find out and see what the statistics tell us. Okay, I'm a numbers guy. I like to look at the numbers. It's very easy to identify and have these ideas and make these claims, but until you really kind of get into the numbers, that's where, the proof is in the pudding, so to speak. So let's take a look at that and kind of examine, see what we have. But before we do that, wait, I am an educator, so you got to have tests, right? So a pop quiz for you guys. So which age group do you think is most likely to have caught or catch COVID-19 in Texas? 20s, 30s, 40s, 50s, 60s, 70 plus. Because, I used to hear a lot of people say, oh, and I've had students and clients say, I ain't worried about COVID, man. That's an old person sickness, right? It's you ain't old, you good. You ain't got to worry about it. It's not going to be an issue, right? Think about it for a second. So what do you think, Ada, these different decades, I'm talking just in Texas, not across the world or in the nation, just in Texas, which age group do you think is probably most likely to have caught Texas? Okay, you guys got in your mind? Okay, you can post in the chat if you want which group you think it is. And so that will kind of give you an idea. And are you ready? Here are the results. Look at that. Oh, I was about to put an emoji. Look, the 30-year-olds, it's them dirty 30s, y'all. That's what is it. Look at that. Over 21% of the case investigations were 30 to 39-year-olds. It's not the old people. Now death rate's a little bit different. This is just the positive cases. The highest risk was in the 30 to 39 year range. And if you notice and you look at it, actually, if we combine the 20, 30, 40, and 50 to 59 range, this right here comprised over 76% of all the positive cases in the state of Texas, between 20 to 59. And if you get into think about it, it kind of makes sense, because these are individuals that are probably out and about, they're working, them young 20-year-olds and 30-year-olds, they're still trying to do stuff. So that's where the bulk of the cases came from. It's not the old people, it's not the little kids, it was just young middle adults. Those are the ones that were catching the bulk of it. And so you bracket off, that would be our bell curve, will be right there between the 20-year-olds all the way to the 59-year-olds. So if you guess 30s, you pat yourself on the back, you did good. Good job, good job. Okay, and that's where most of our cases we saw in Texas. But now if we contrast that, look at this. Oh, this is where we see the degree of difference. But when we compare fatalities, then yes, it's older individuals. So young to middle adults were more likely to have caught COVID, but the significantly older you are, then the more likely you were to pass away. And it's really kind of a significant steep when you get to the 80 plus. That's, we jump from 13 in the 70s up to 30, well, combined, I guess that would be, 26, but then the 80-year-old, that's the 32, almost 39%. That's where the bulk of our fatalities were caught. And really, if you think about it, and there are a few younger cases, but there were very, very few compared statistically to older adults. So that's where we see the big degree of difference, is the fatalities were in the older aging population, but the cases were more in the young adult, middle adult population range. Okay, that's kind of what was going on. Now, another pop quiz. So which racial or ethnic group do you think was most likely to catch COVID-19 in Texas? White, Hispanic, African American, or Asian? And I bet, given the name of the presentation, you're probably going to guess that is correct. Hispanic, Latino. Almost 36% of the cases were Hispanic, Latino, compared a close second for white, non-Hispanic population, followed by African American, Asian, and then other. But still, pretty large population with the Hispanic, Latino population as far as being impacted or affected by cases. This is not fatalities; it's just cases by by ethnicity, okay? Now you're probably thinking, well, so what? Because, Hispanics make up most of the state's population anyways, right? Wrong. You would think that, right? Maybe in the very near future, but not yet. So according to the US Census Bureau, as of 2019, that was the most current one I could pull, Hispanics make up 39% of the state's population, but white non-Hispanic Latinos still make up over 41% of the state population. So you see, that's the difference, that we still have more white folks, non-Hispanic white folks in Texas, but yet Hispanics are having more positive cases at higher numbers compared to their white counterparts. So that's pretty, now it's not a huge degree of margin, but again, it's still more that we have to look at. And I could further probably run some statistics on these numbers to kind of see, but that's currently what our state population. Probably in another few years, projections are saying that yes, Hispanic Latino population will exceed all other groups in the state of Texas, but not quite yet. Again, this is based off the US Census Bureau, what I looked at. And we have currently a total state population of just about 29 million. That's our total state population. And see how those break down. But now what's interesting to me in this particular instance, it's not so much just the cases that's important, but here's also what's even more interesting. Look at the fatalities. It's even higher for Hispanic Latino populations. We're literally dying from the COVID, okay? Literally, it's 46% or higher. That's a bigger degree of margin compared to only 40% for Hispanic Latinos. Or I'm sorry, compared to 40% for non-Hispanic whites. So again, the margin of difference is even larger. And I just said a second ago, we still have more white people in Texas than Hispanic Latinos, but yet we have more Hispanic Latinos dying from COVID infection. And so that's another, factor we need to take into consideration. Followed again by African Americans at 10%, which is still statistically significant, but less than half of what the Hispanic population fatality rate is. And this is currently in Texas. And again, these numbers are updated every week in Texas. And so just go to the Texas website for Health and Human Services and you can find this information and kind of pull from there. Yeah, so that's kind of some of the demographic data to kind of give you an idea, an overview of what's happening in the good old state of Texas, okay? But we got a vaccine, right? So it's all good. We ain't got to worry about it because the cases and COVID's going away, right? So nothing to worry about, or as say, nothing to look at here. Keep on moving. We good. Let's hold on just for a second. It's not as good as we think. Well, what about the people taking the vaccine? So here's what we have to look at. So this is data pulled from the CDC. And this is more of national data. I didn't have enough time to pull and see if I could break it down for state data, or at least it wasn't easily accessible to me at the time. But as you can see, we have a degree of difference where much larger percentage of the white population, non-Hispanic white population, is taking the vaccine. So look over here in the red, this is the first dose, the blue is second dose. But in the first dose, we still see it's upward of close to 60% of white non-Hispanic persons taking their first doses of vaccine, compared to well under 20, that's probably right around 15 or so percent of Hispanics have taken at least one dose. So the light pink is persons who initiated vaccination within the last 14 days, and then the darker red dot is percent among persons that have taken at least one dosage, and the gray is just the percentage of the U.S. population's demographic. So as you can see, that's where we see we begin to see some of the disparities. And when you look at the blue, here we can see for the second dosage, again, it's still significantly lagging, where it's still far under 20% compared to nearly 60% for white non-Hispanics. So what does this mean? Well, the Hispanic Latino population is just not getting vaccinated, in comparison, or as often or as frequently compared to other ethnic groups. That's something we need to think about. And again, if you think about it, and for those of you that are Hispanic Latino in the session, think about it. How leery are you and your family members about taking the vaccine? I don't know, I'll be honest. I've had to have discussions with my cousins, my tias, my mom, she didn't want to take it. There are a lot of people that are just very leery. They're like, oh no, I don't need it. I don't need it, and again, you can remember, for the Hispanic person, we don't really, going to medicine, I think, Dr. Torres alluded to this earlier in his keynote, that's just not our go-to. We're not going to do that. We're going to pray. We can go see the curandera, we're gonna do other stuff like that. We're just not gonna go look, especially we're talking about a vaccine, that's just not something we're gonna think about. So that's not gonna be our number one first go to. So this is something we need to take into consideration within the Hispanic Latino population. So what factors are really affecting these levels of disparity within the Hispanic Latino population? That becomes really, that's kind of like the overarching topic that's guiding my presentation, or really guiding my curiosity. That's what I want to know about. What's really motivating this? What are the factors? If you think in research terms, what are those variables, man? What are the variables that are affecting these outcomes? So we know the outcome. That's the outcome, right? There's plenty of data to substantiate that's the outcome. So how are we getting that outcome? What is contributing to that outcome? And I think that becomes important, because that's what we as clinicians are going to want to look for. Well, according to the CDC, there are health inequities and certain considerations for racial ethnic minorities. And these will apply not just to Hispanic Latinos, but also to other ethnic groups as well. And so when you look at that, they recognize and they boldly proclaim their longstanding systemic health and social inequities that have been have put many people, particularly racial and minority groups, at increased risk of just getting sick and dying from COVID infection. So that's the CDC. They're saying, yeah, that's just the reality. And it's these inequities, and there's certain inequities that exist within the social determinants of health. And that's what we have to look at. So they've already identified there are certain social determinants of health. These are like factors. So think of these as the variables or the factors to determine how healthy a person is. I think Dr. Torres mentioned earlier, he talked about the app where you can check your zip code and now to determine, how long you're going to live. Well, there are factors. So think of poverty and healthcare access. Those are like the apps to do that, okay? Those are going to be the variables that can correlate to a person's overall health. And then health can be extrapolated to both physical health, and then we're going to look at mental or behavioral health. So that's when you look at. So think of poverty and healthcare access as a couple of these social determinants that determine how healthy a person is or what their health is going to look like. And then likewise, as we see the impact or the effect on physical health, we can see the same thing happening to behavioral health outcomes. And I'm going to go ahead, I'm going to tell you, in case you don't have time to stay for the rest, or you're getting hungry, you want to go to lunch early, the behavioral health outcomes are going to be worse. Basically, what the COVID infection has done, it has exacerbated what we've already been seeing as mental health professionals. And then you guys can, or if you think I'm crazy, you can post in the chat and say, man, this guy's loony, no, it's not what I see. But if not, that's kind of what's going to happen down the line. Health outcome, the physical health outcomes are going to lead to worse behavioral health outcomes. So what are some of these social inequities or some of these social determinants that cause the social inequities? Well, according to the CDC, they've identified a few. The first one, discrimination, obviously, well, duh. And it's crazy how some people, and I see it all the time on social media, they talk about, well, racism isn't real, it's just in the past, or, whatnot, it's not that big of a deal, or just get over and deal with it. You can't undo years and generations of institutional racism overnight. And it's funny because I used to tell my students, I would teach, especially my undergrad social work class, that, things are getting better, race relations are improving. Man, after 2021, after 2020, they ain't getting better, they're getting worse, man. It's getting crazy, man. You see all the social protesting and whatnot going on. It's just crazy out there, man. It's really wild, it's funny because, so I go to a men's group at my church, and I went there, and of course, I think there's like one other Hispanic guy, there's no Black people there, and the rest are all white guys. I'm sitting there thinking, I never did this before, but now I'm thinking, I wonder if they're looking at me funny. I wonder, how they feel about me because I'm not white. It's interesting. And I never thought of that before, but after 2020 and all the craziness, now I'm beginning to think different. I'm beginning to question and wonder how people perceive me. So anyways, enough of that. So the other big factor we have to look at is healthcare access and utilization. That's a big thing. And Dr. Torres also spoke about this earlier, that we have to take into consideration. The many racial ethnic minority groups, they're more likely to be uninsured. We have stats to show that compared to non-Hispanic whites, and then the access is going to be more difficult. So that's going to become a barrier. So when you're taking a population that already doesn't trust the healthcare system, that has been discriminated against, and then they don't have access to it, that's a triple whammy. That's really going to cause ripple effects when you look at overall health outcomes. That's another big factor. Then we have probably one of the most significant ones, in my opinion, is occupation. So think back again when we did the timeline, and I said, all right, think back to what happened when everything shut down. Well, as a college professor, man, all I had to do was, jump on the computer and just do more teaching online classes. But, if you worked in a restaurant or if you did construction, or if you were in lawn service, maintenance, whatnot, you can't just do that online, okay? That's not possible. Or if you're a small business owner, that's where we saw the real impact of transitioning to, shelter in place, quarantine, and work from home virtually. That's just not feasible. And even for individuals that were in professional careers, we all know the challenges of trying to do presentations whenever you got your kids coming in every 5 minutes, wanting to crash and photobomb your Zoom session. That just happens. That's just the reality. So having to manage that is very intensive. So if you think about it, it's just greater when you're talking about more of an indigenous population or an historically oppressed population that just doesn't have that opportunity. For most individuals, when things shut down, that's it. I have plenty of clients that work in construction. Well, when there's no construction work, they're not getting paid. They don't got workers' comp. They don't have those factors there. They don't get severance pay. It's just like, hey, sorry, we're closing down, or you had a job. Nope, that's it. Nothing to do today. That's it. So, and I'm going to share some case studies a little bit later that further can illustrate this, illustrate the impact of this. So that's going to be one, is that we see there are disproportional rates or representation with Hispanic Latino populations in those particular fields that just cannot translate well virtually. And then of course, obviously education, income, that's where we are now seeing a drastic shift, where what I see happening, and again, I'm going to go and look at some more research, but I'm also so I'm fascinated by the health outcome, behavioral health outcomes, the disparities, but I'm also fascinated by the economics of our country. And what I'm seeing, tell me what y'all think, but this is what I'm seeing. I'm seeing slowly a shrinking of the middle class in America, where I'm seeing a greater divide between the haves and the have-nots. And this has always kind of been happening, because I've been following this, or looking at some of these economic trends since the early 2000s, or really since the first, or the first economic recession that I remember, which was back in 2007, going to 2008 after the housing market crash. And that's where I saw a lot of that happen then. And now I'm seeing it again, where people are being displaced. They're being, the forbearance is ending, so people are being pushed out their homes, rents going up through the roof. So we're just seeing greater issues related to housing, related to income. Stimulus pay, is not a whole lot, and then it's been put on the back burner. So we have a lot of economic inequities when we're looking at wealth distribution in America. And so basically the wealth is kind of shifting. If I had more time, I'd probably put a fancy little graph or slide here to show how it's shifting, where we have a small percentage of the class that is just growing financially. Because again, just like with anything else, you're gonna have your losers, you're gonna have your winners. Well, man, the winners are winning big. People who are able to transition virtually, who are able to start online businesses, they're doing well. You look at some of the major companies, you look at places like, like Target, man, booming for business, but other places they're not, like JCPenney, what are the Neiman Marcus, man, they're even having financial trouble. So we see that in retail, we see that in the restaurant industry, we see it in a lot of different industries where we're seeing a separation between those that are able to adapt to the changing environment economically and thrive, and those that cannot. And that's where the problem lies for us, is because there are a lot more in the other side that are just not going to be able to make this shift, or that are now going to be behind. I mean, think about it. If you were living paycheck to paycheck, it's tough, right? That's just tough on average. But then if something happens and your paycheck stops or it's put on hold for a while, then bills are still there. So what happens? Now you're in the hole, you're behind. So you now don't have enough income to take care of your regular monthly bills, but now you got to make up for the stuff you went behind on, all right? Your car gets repossessed, you get kicked out your home. So it just creates a ripple effect. And so now you're having to basically make up. Think about it like in school, it's like you miss a couple assignments and you're already having trouble with the first assignments. Now you got to redo those assignments, and then you still got to do the next assignments that are coming next. So it just creates this cascading effect that people just cannot overcome, and the way just stagnant. It just happens. All right, and then the last one is housing, and that's where, man, oh my gosh, Texas housing is crazy, man. It's bonkers right now. You guys have probably seen this, So it's really interesting where, fortunately, I was lucky enough to be married to a very smart woman who said, Phil, let's put a contract on a new house and get a house built. And we did this back at the end of 2020. And I was thinking, no, so let's just wait. We'll get one in the springtime. Don't worry, I'm gonna keep saving some money. We'll be fine. Oh my gosh, I'm so glad I did. Because man, houses prices are crazy right now. And so literally the house we went on the contract for back in December of 2020 has literally increased $125,000. The same floor plan they're selling for $125,000 more than what my initial contract was. And I called up the home builder and I said, dude, I need you to be real, man. Tell me, now, are y'all gonna jack the prices up? Because I need to prepare for this and come up with some backup plans or some contingency plans, or at least tell my wife so she doesn't go crazy. So, we need to prepare for these kind of things, because that's what, and you'll read about in the news where some of the home builders, they can command and get over 100,000 more than what the original seller was willing to offer. And so it's just crazy times right now. So for an average person that's just barely getting by, there's no way you can do that. How can you come up with 50, 100,000 more to put on top of a house? That's just going to be, a crazy problem. And especially a lot of times, even with Hispanic Latinos that have historically have been really cash heavy, they may not have the credit to do that. So when the cash amount gets to a certain level, you can't do that unless you just got, bukus of dollars sitting in the bank. It's just not going to be feasible. So those are some factors that we have to look at and think about how it's affecting individuals. And maybe it's affecting ourselves right now. And that's where we're going to see the displacement, which I think will further compound the economic divide in our nation. All right, so let's move on. So that was CDC. What's the APA saying about it? Well, interesting, and I wanted to add this, it's kind of semi-related, but at the beginning of the year, the APA finally recognized, man, there's been a lot of, sketchy practices and things going on in the mental health field, and they issued a formal apology to Black, Indigenous persons of color. And they boldly say right here, we want to apologize not to the members and the patients and their families for discriminatory, prejudicial actions, aka institutional racism, in psychiatric treatment. And so he finally recognized that, it's not been all peaches and cream, that there have been some issues, and individuals have had negative impacts as a result of this. And think, I don't know if any of you guys are practicing right now, but how often do you have a client come in for service and they'll just tell you, yeah, I had a bad experience with my last therapist, or, I don't know if I should trust you because the last therapist, they were kind of sketchy, or they were a little shady, or they were just rude, it just happens, all the time within the field. And that's one of the things we have to look at. So the APA is really trying to make attempts to say, okay, you know what, it's kind of like saying, you were right, man, I messed up. It is what it is. But we're going to try to look at rectifying the past and look at developing anti-racist policies. And if you think about it, this is kind of what guides everything we do in mental health, right? They pretty much decide what is a mental health disorder and what is not a mental health disorder. So that's kind of the go-to. So that's where it's really important that we have a greater degree of congruence between what we're seeing with the population and what people are experiencing and how we as providers are treating individuals. That's one of the things I think we want to look at. And the APA pretty much sets the gold standard. I mean, think about it. That's why we refer to the DSM-5 as the Bible of mental health. Who made the Bible? These guys did. And they just admitted that there have been historically racist practices that have infiltrated mental health. Now, I think as a way, in addition to further add to that, or to undo some of that, they now have put out these little fact sheets. And so there's one for Hispanic Latinos. I'm not sure, I didn't check to see if they did one for Asians or African American populations, so forgive me. But I know that I did find one they did for Hispanic Latinos, where they acknowledge and recognize that because of longstanding inequities in our country's systems and structures, Hispanics are just at higher risk for physical, mental, and financial problems as a result of the COVID pandemic. That's just, and they're more likely to go to the hospital, and 2.8 times more likely to die of COVID infection. So that is, again, their recognition that there are disparities and that there are some factors that we need to be aware of, specifically as it relates to working with Hispanic Latino populations. And that's not me saying this, that's the APA saying this. And so, you can just, Google it, or if you want, I can forward the link for this, for APA mental health fact sheet for Hispanic Latinos. So I'm glad, because it's a step in the right direction, at least just admitting that, hey, there are some, health inequities and some social factors we need to take into consideration. SAMSA, another major organization, they also identified and talked about the coronavirus pandemic as having the deep-seated inequities in health for communities of color, and it really amplifies social and economic factors. And that's kind of what I've been able to pull from the research, is that basically what COVID-19 did is it just took what was already happening and what I already knew and saw with my clients that I work with and with students that I teach, and just made everything worse. It's kind of like it brought it to light. It's like it took a flashlight and shined on it and said, this is what's going on, man. This stuff is getting crazy and it's getting worse for people, especially for ethnic minorities. And when we look at Hispanic Latino populations, that's where we see the greatest disparities, I believe, at least when we look at the state of Texas, okay? So that's kind of, what's basically happening. And then they know. And so SAMSA recognizes that Black and Latinos have substantially lower access to mental health services and substance use treatment providers. That's just, the reality, that we live in. And honestly, it was really interesting, because I remember when I first got connected with the NHL ATTC or MATTC, who was, I think they're helping sponsoring this conference. And so, they flew me out to Puerto Rico, and it was really interesting. I think actually I went to University of Houston, where Dr. Torres was the associate dean at the time. And it was really interesting. It was wild, because I thought, oh my gosh, this is crazy. I've never seen this many Hispanic Latinos with PhDs in one room at one time. Because I'm always the only one at every agency I've worked at. I've always been the bilingual counselor at every time. So it was really great to see that now I have colleagues in the community that I can use and tap for resources, because I just didn't have that before. I always felt like I was just kind of, on my own. So I really encourage those of you moving into this field, really keep that. And all the HTTC networks, they're all very important. They all provide a lot of additional training, and they're great for connecting. So that's just a little plug-in for them to keep that in mind. All right, so back on topic. So also, according to SAMSA, we're seeing that there are existing impediments in the care for African Americans and Latinos as it relates to the behavioral health problems, because that's basically now making us more vulnerable to the behavioral health outcomes. And, you just think about it, that's kind of what happened. So all of us probably, I suspect, had a hard time. I think about it. I remember when this stuff was going on, I was feeling a little anxious, because I didn't know what was going to happen. I didn't know if my classes were going to get reduced. I knew one of my major contract providers, it was put on hold. So this was, income that I was already dependent upon, and I didn't know what was going to happen. So I was like, all right, I got to go to, operation emergency mode, cut expenses, because I don't know how much my income is going to change. All right. And then we had to switch to doing things online. And that was a lot. So, and then even prepping for this presentation, I'm like, okay, I got to get familiar with this particular software. I got to log in. I got to do this technology check. I got to do that. Man, it's very nerve-wracking, a little bit anxiety, provoking. Now, keep in mind, I have a doctorate in education, and I was already nervous about logging on to figure out how to get the Zoom conference working right. Imagine if you're a person who has recently migrated to the United States, and then now your school says, oh, we're going to school online. You can pick up a laptop, and then you go ahead and log in, access, put in the correct code, make sure you set up the software, download it, install the app, update, and then you'll be good to go. So imagine you got to do that, and you don't even speak English. Man, that's crazy. Now, my sister, who's a teacher, she told me that, I'm not making this up, that's what she told me. She said she had a family that recently migrated from Colombia. They didn't speak any English, and they never had a computer. And she's having to explain to them what Wi-Fi access is in Spanish, okay? So the educational disparities are going to be significantly enhanced. And I think teachers are going to be really hit over the head going into this next school year, because now everyone's really coming back. And I think they've already been back. They ended the year where they're already having a lot of face-to-face instruction, but a lot of school districts were kind of mixed. Like I know my daughter still had the option of going online for a large percentage of the time, but now they all have to come back. And I think now we're going to see the difficulty where people are going to be at all kind of different levels in relation to educational attainment. And we're probably even going to see it at the higher education level. So Dean Lacey, get ready, because we're probably going to see that, because all those high school students are going to be coming to college, and they're going to want to be getting degrees in human services and counseling, and they may not be ready. We might have to work on their writing skills, or, again, that's another thing that we as faculty educators need to prepare for, because that's, the after effect, and that's the aftermath. So we got to keep that in mind. All right, I got to move on, because I don't think we have enough time to cover all this. Okay, so, all right, so that's SAMSA. So here's a recommendation. SAMSA recommends, there are a couple of things we need to look at. One, we've got to, as providers, we've got to be flexible, not just in our services, but in how we pay for services, in the treatment policies, I've kind of always done this, but I really began to push for a lot of the clinical evaluations I do. I always give my clients a payment plan option. And I tell them, I can't really just, give you the service for free, or I can't just cut it in half. There ain't no 50% discount. But what I will be happy to do is establish a payment plan. You pay what you're comfortable with. And then once you're finished, then I release the report. Because a lot of my clients, they needed to go to court and whatnot. So, I tell them, I'll work with you, but, we have conversations about that. But our policies have to reflect that as well. It's not enough just for a service provider to do that, but you got to look at the insurance reimbursement. You got to look at the co-pays. You got to look at the agency programs, how everything we've got to go through a paradigm shift where everything has to change in order to deal with the new reality. Also with telehealth services. And, my wife is an LPC and she does full-time private practice. And they're always going back and forth. The insurance is 1 minute saying, okay, we're going to cover and reimburse 100% for telehealth. No, we're only going to do 50%. No, we'll do 65%. So they're always changing. I'm like, oh my gosh, it's maddening because she never knows what she's going to get paid. So if we can have greater consistency, at least knowing, because we still need to keep that option. Because I don't know if you guys have heard, we've got a couple of COVID variants going on. And so that Delta variant's on the rise. California, they just went back into, mandating masks, and, we don't know what's going to happen. So this is not something that's just gone completely. We have to be prepared for what's going to continue to come. So we're probably, and what I'm seeing with a lot of the agencies I'm working with, they're doing a mixture where my contract provider said, yeah, we want you to come to the office at least once a week and do some groups, but then you can still do telehealth services for the clients that want individual counseling or can't come remotely. Obviously, language, culturally appropriate services becomes very important. And then we really need to look at how else can we expand opportunities for remote or telehealth services, in case the infection rises go back or in case the numbers go up, which we're seeing a slight increase. And I didn't put that when I did the Texas stats, but they, according to the Health and Human Services Department, they are kind of seeing some of that. And then really relying more on additional service providers with the peer navigators, especially treatment. For those of you working in treatment, peer recovery coaches, don't hesitate to make use of these additional providers, even if they're not full clinicians. Then that's another a group of individuals that really can help, and we can cross coordinate our services for individuals. We don't have to do formal, counseling all the time. There's many different services. All right, so quickly, I'm going to touch base with a couple of cases that I worked on that were really affected or impacted when the coronavirus hit. So the first one is I had a 16-year-old Hispanic Latino male, and he was charged with attempted kidnapping. And the story is more a situation where there was a little girl walking across the street. He saw a car coming, so he went and grabbed her, moved her out the way so the car wouldn't hit her. Then I guess the parent came out or a family member came out, saw, and they thought he was trying to kidnap the kid, so they filed charges on him, got him arrested. He got 2 years of probation. So here's what happened. So again, he was referred to me for counseling. And then during the process of counseling, then this basically happened. Coronavirus hit, but here's the problem. His grandparents, well, think about it, this is how they earned their living. Grandmother would make and sell tamales, and that's how she made her money. And grandfather would go to the flea market and sell stuff at the local flea market. That was their source of income. That's how they made it. Oh, because the kid, he could no longer reside with his parents because they also had minor children. So the court said, no, you got to stay with another family member, or you got to come into a CPS care or detention. So he was able to go stay with the grandparents. So coronavirus hit. So guess what? And I forgot in which order it came. I think the grandfather tested positive first, got really sick, so he couldn't go to the flea market and sell. Then grandmother got really sick, so she can't make the tamales, and she can't go and do her her tamale delivery drop off on those orders. And then the child got sick. Then all three of them are sick. Zero income, no medical insurance, no income, no treatment service. And it's not like it was not like a mild case. They were severely sick. So it was over a month long, a severe respiratory illness, especially for the grandparents because they're older. So that's one of the things we had to deal with. And I had to look at really providing support and doing a lot more phone check-ins with him and really trying to help them access other resources so they could help with the healing process. And again, they were still worried about the legal issues dealing with, the grandson. It was just a lot. Okay. I'm going to wrap up. Then the last one I had another 15-year-old Hispanic kid who was charged with capital murder, and he didn't actually commit the murder, but they were planning to go rob this other kid. And so it just so happened the kid also had a gun, pulled the gun out, and the kid, the intended victim, ended up shooting one of the offenders and died. And then they blamed the kid that I had to work with. But the problem is when we went to quarantine and shutdown, the kid is sitting stuck in the juvenile detention center, but now we have no way of accessing them because they weren't allowing anybody to come in and provide counseling services or medical services or whatnot. It was only whatever was in-house, and it was very limited and restricted. So again, the kid was grossly depressed, significantly anxious. And think about it, imagine you're a 15-year-old kid and you've got the most serious charge you can possibly get, and then bam, now you can't have access to anybody. Family couldn't even come see him. They were able to occasionally set up video FaceTime sessions, but that was it. They couldn't come in to see him. So it was crazy. And I had to request and give 2-week advance notice to schedule Zoom sessions with him periodically at the discretion and permission of the COs. So it was very, very difficult and challenging. Fortunately, in both cases, the grandparents have healed. In this case, the kid was released, but he did get a 10-year probation, which is better than having to go to jail for 40 years for capital murder. All right, so anyways, I need to go ahead and wrap this up. So again, my research questions were, has it affected Hispanic Latinos? Yes, it definitely has. We have higher numbers of case infections and mortalities. Has there been impact on mental health services? Yes, according to CDC, APA, and SAMSA, definitely. And what are the implications for service providers? Well, hopefully we got that from this presentation. Flexibility, expanding, and really having a paradigm shift in how we provide services, I think will be monumental going forward. And I think that will hopefully wrap this up. I now invite any comments or questions from anybody.
I just want to say, Dr. Ortiz, your mentor, Dr. Ortiz, that this is phenomenal information, and there's been a lot of conversation in the chat. So you've hit home, you've hit a home run with and making us, thought provoking. People are saying this is awesome. This is very helpful. This affirms, many of them teachers, social workers, counselors. This affirms their experience. Would you please put your email in the chat so people can reach out to you for additional information regarding the National Hispanic Mental Health TTC?
Yes, absolutely. So I will put my primary email address, and then I can forward anybody who would like more information about the Hispanic Latino MATTC as needed. Or if you would like to look at setting up or scheduling an in-house training at a different agency or further collaborations, let me know, and we can negotiate that as well, if that's the case. So yeah, and so absolutely. So I encourage you guys, education has been the key for me to be able to improve myself economically. And for many of our people, that's how we do it, I mean, I'm not a celebrity. I'm not going to be YouTube famous or Instagram famous. It's really just looking at the education. And again, it comes back to just hoping to help and make a little difference. If I can.
One of the things I think that you're bringing to the table that we need to, particularly in higher education, think about is having these conversations embedded in our curriculum. I really like the way that you talked about how you share this information, or you get your students engaged. And so I'm going to challenge my colleagues who are on this in this session and in our other sessions to really find a way to start to embed this information in your curriculum. And I'm going to challenge students to start asking for it in your curriculum. It's one thing just to get the textbook, but it's another thing to start getting information and processing and researching information that's relevant to you as you leave this field and go out, leave the school and go out into the field. And it will also help increase our vocabulary as service providers, clinicians, counselors, therapists, doctors, when we talk to our constituents in the community.
Yeah. Oh, absolutely. By all means, definitely. Well, thank you for listening. Thank you for checking out, my presentation. I appreciate it. I ain't gonna lie, man. I was a little bit nervous, low key, man. A little bit nervous, but I was like, I'm gonna go through and look at all these the comments. But I hope you guys enjoyed it, and definitely hit me up if you have any questions or if I can be of service to you guys.
You did a fantastic job. Thanks everyone. Have a great rest of your day. We are done for today. This symposium is at a close, but I think this is start to generate some hunger and thirst for more conversations such as this. Thank you, Dr. Ortiz.
My pleasure. All right, y'all have a nice one.
Bye-bye, everyone.
Bye-bye.